And welcome to today's webinar. It is my great pleasure to introduce our today's speaker, and that is Dr. Paul Brennan. He's a specialist trainee in hepatology and research fellow at the University of Dundee, NH Tayside, and he's also a member of Global NASH Council. So Dr. Brennan is a translationally focused clinician. He has trained at some of the top UK's centers, including Yorkshire, Edinburgh, Dundee as well. So he completed his clinical lectureship at University of Dundee, and then also he did his doctoral studies and advanced hepatology training at University of Edinburgh. In particular, I think it was Scottish Liver Transplant Unit, if I'm correct. And his main research interests are identification of liver disease, especially in primary care and early diagnosis, and also understanding epidemiology and natural history of the disease, and as well as connection with other morbidities linked to steatotic liver disease, so metabolic dysfunction, cardiovascular, renal complications as well. So, and as we heard a little bit before, he's also interested in the development and delivery of cell-based therapies for chronic liver disease. So today's topic will be extrahepatic cancer associated with MASLD, so understanding the pathogenesis, burden of disease, and treatment approaches. I think this is it. If you have any questions during the presentation, feel free to drop them in the chat box, and then we will address them at the end during the Q&A session. And I think this is it. So Dr. Brennan, over to you.
Thank you so much. A really kind invitation to come and speak. So I'm definitely not an extrahepatic cancer specialist, but I think we'll all agree as hepatologists and clinicians, it's something that we're probably going to see more and more. So I'm just going to try and share my slides again. So can you see this okay?
Yes, but there is kind of like a gray box at the bottom of the screen, hiding like the bottom part. Yeah, before we tried it was okay. I think it's getting better now.
Is that better?
Yeah, it's okay now. Yeah.
Just want to let me move my slides. Let me just, is that still okay, or can I?
Yeah, it keeps appearing again, like
Is it? No.
yeah, now it's still only at the bottom, like that gray box. Now it's okay.
So these are just some of my disclosures, obviously unrelated to what I'm about to present today. So just as a brief overview, I thought we will try and touch on some of the basics about why it's important for clinicians to be aware of, some of the epidemiology, pathogenesis in terms of underwriting disease processes. We'll look at some of the epidemiological evidence and current thinkings around the prevalence of these conditions, and then we'll think a bit about treatment approaches and how we may influence the natural history of the disease. And then we'll come to some concluding remarks and discussion. And hopefully there's some provocative statements in this that I think, again, should challenge some of the dogma and what we see in the data, and provide some thoughts for, again, future directions for the field. So hopefully most people are aware that this is the new nomenclature. It's been around for at least a couple of years now. And I think what's really important about this is it's given us a new umbrella term to begin to think of the dynamic spectrum of the disease, and moving away from the idea that this is just a static binary definition of MASLD versus MetALD or alcohol. And actually, there's some really nice data that actually shows that if you follow up patients long enough, even over a 2-year interval, the group in Odense showed that actually people can flux between having no steatotic liver disease to having definitions that would be compatible with alcohol-related liver disease in a 24-month interval. So again, I think that's really important as we think about what we see in the data, and understanding when we see these patients in clinic, whilst they may have a nominal diagnosis of MASLD, what happened 20 years previous may have had a significant bearing on the clinical picture that we see before us in clinic. But I think overall this has been a helpful progress in terms of being able to ascribe a new definition for the disease. And so we'll have seen that NAFLD and some of the old studies will still relate to NAFLD. I have updated it to just reflect MASLD because we know there's huge relative homogeneity in the definitions of about 98%, but there is some small outliers in that. And then we will maybe even touch on some MetALD because I think that's a really important part, even though it wasn't part of the initial descriptor for reasons that hopefully will become apparent. And so what's the definition? So again, this is really the idea that we have established that there's steatosis in the liver, or some fat within the intraparenchymal space within the hepatocytes. And then it's really the presence of some of the cardiometabolic risk factors that make up the definition of the metabolic syndrome. So insulin resistance, and again, that will become obvious as a real primary proponent of fibrogenesis and producing worse outcomes for patients. The presence of obesity, which is usually centripetal, presence of essential hypertension, and then metabolic dyslipidemia. And again, thinking back to the nomenclature changes, it's important to recognize that, again, as we begin to see that individuals who consume too much alcohol can also significantly have metabolic risk that, again, may inadvertently end up in a misnomer of having MetALD when actually they may actually be closer to ARLD, and that's important in terms of defining their prognosis and clinical trajectory. So where are we in terms of our global prevalence? So we see per decade, we're just massively increasing our global prevalence, and we're seeing huge geographical variation in terms of where it's being most likely affected. So again, we're seeing emerging economies, people in the Middle East and North African regions who probably now have rates close to 55% in terms of their background population. And again, it's probably important to contextualize that if we look at the global burden of disease, about half of the world population with type 2 diabetes remain undiagnosed. And so again, we suspect that a huge proportion of these individuals will invariably have MASLD. And so actually, we're probably still only seeing the tip of the iceberg, and recognizing that these epidemiological studies are only using ultrasound defined coding, which again is only about 70% sensitive. So it's an important limitation to bear in mind, that actually we still probably have very little grasp of the true underlying prevalence. And then extrapolating that further, as we said, type 2 diabetes is probably one of the strongest proponents in terms of more progressive disease. So again, we see individuals with type 2 diabetes that can then have increased risk of developing advanced fibrosis, which is the determinant of outcomes, particularly in terms of liver-related events, but not just exclusively. And again, we just have a bit of a better pictorial capturing of these changes in terms of the prevalence of disease. Now he says West Africa, North Africa, Middle East are showing huge trends to increase their overall prevalence. And that really mirrors the changes that we also see in terms of their background changes in type 2 diabetes, but also in terms of their background prevalence changes in terms of obesity. And that is really the natural mirror that we're seeing in terms of what's driving the majority of the disease that we're witnessing. So one of the challenges that we have in terms of what's defining outcomes in MASLD, and as hepatologists, we're obsessed with fibrosis because we've shown that reproducibly it predicts outcomes, certainly in terms of liver-related events. And there's a natural inflection point between those individuals who have F0 to F2, and then once you develop F3 and F4, your risk of developing liver-related events increases almost exponentially. And again, we wonder that can also translate to all-cause mortality. But a lot of the data that we're deriving from this is, again, taken from clinical trials. So we have to be aware of the limitations of this. And this is the Arun Sanyal's paper from New England Journal from about 3 years ago. And again, taking from the Flint study and some other NAFLD and NASH trials, we looked at, again, was there a difference in how patients could be categorized in terms of the cardiac and non-cardiac events and liver-related events, but also the cancer risk. And again, if we can adjust, again, across multiple variables within a limited observational cohort, really, of those who are willing to undergo biopsy, that we could see that actually, depending on baseline histological severity, the risk of hepatic decompensation was essentially fundamentally associated with their fibrosis stage. So again, there's probably a natural inflection in terms of competing risks for what patients are likely to succumb to, and those who have much more advanced liver fibrosis may have significantly increased risk of liver-related events, but still have significant risk in terms of for cancer and cardiovascular outcomes. And so I'm trying to think about the metabolic perturbations and some of the homeostatic mechanisms that are involved. And we begin to start to think more outside of the liver. So again, as hepatologists, we're very liver focused, but thinking realist in terms of actually what's happening and the crosstalk that we understand that happens between visceral adiposity and particularly with the development of insulin resistance. And again, looking across the entire spectrum of chronic chronic burden of disease, not just liver disease. Actually, again, the development of insulin resistance is a real inflection point in terms of people's differing outcomes from all-cause mortality. So again, if we think about some of the molecular pathways that are involved in this, we can see changes in standard ability of hepatocytes to handle glucose or other forms of sugar, how we shunt into different pathways to develop this adaptive response. And then we can see the influence of how changes in de novo lipogenesis, the ability to handle lipid subtypes, can go on and actually produce most of the deleterious consequences that we see from these perturbations in lipid handling and glucose signaling. So again, we can see these kind of natural negative cycles that feed back, particularly when we look at things like increasing PKC epsilon, which can then affect insulin signaling. And now, of course, if we already have the development of insulin resistance, we then get this negative feedback. And of course, then further down the process, we can see changes in fatty acid oxidation, increased endothelial reticulum stress, which can lead to mitophagy or very lazy mitochondria, which again worsens the ability to handle all of the natural cellular responses. Would again knock-on effects in terms of insulin resistance, development of inflammation, and all of these negative metabolic pathways again feed into what we'll look at in terms of producing very undesirable pathway activations. So then thinking a bit more holistically, so we can see what happens within almost a cellular level or very limited region within the liver, these very pro-inflammatory milieus of innate immunity, the recruitment of pro-inflammatory cells into the liver, which again drive ongoing stressors. And a lot of these can then become very self-propagating. So once you induce part of these pathways, particularly via non-canonical means, they can essentially continue these pathways without, even if you remove some of the initial stressors that may have started the activation. We also see significant systemic changes. So we think about dysbiosis or changes in microorganisms within the small bowel, and particularly we then introduce external or exogenous toxins in terms of pro-inflammatory diets, ultra-processed foods, which again are becoming increasingly to the fore in terms of disease pathogenesis. And then we can see that ultimately the things that really drive disease outcome are probably this really prominent inflammasome activation and chronic inflammation. And all of these, again, can have significant end organ dysfunction that we see across the risk of breast cancer, pancreatic risk, but also induction in cardiovascular risk, atrial fibrillation, stroke disease, and colorectal cancer in particular. But again, important to recognize that the two main outcomes for patients with MASLD remain neoplasia or cancer, but also cardiovascular risk. And it's these competing risks that we have to think about in terms of that discrete individual. And one of the things that when I spoke to somebody about this talk really was trying to define what is it about the pathophysiology of MASLD that's uniquely different from obesity. And I think in terms of being slightly inflammatory, I would suggest that actually they're probably two sides of the same coin. And again, I think we can debate the intricacies of that. But MASLD is probably just a reflection or a window into the metabolic health of that individual, or the sequelae of their insulin resistance and visceral adiposity. And we see that importantly in terms of bariatric studies, and most of these are derived from our colleagues in the Scandinavian countries. So we've one from Denmark and we've one from the wider Nordic countries. But again, bariatric studies, which were successful, demonstrate an enormous reduction in overall cancer risk. And as we said, this idea that if we can reduce the chronic inflammation, that this appears to be the inflection point that really sparks these downstream effects. Most of the pathways appear to converge on this idea of NF-kappa B, which is involved in rank and rank ligand signaling, and is a very pro-inflammatory cytokine, and again drives lots of these canonical and non-canonical pathways that drive ongoing inflammation. And in terms of carcinogenesis, the field is enormous, but there's kind of, again, four main aspects that we think are probably most likely culprits that we can see from some of the initial pathways that we looked at, and that's the development of reactive oxygen species, IGF-1 signaling, which again is probably not surprising because actually we do see that significantly upregulated in things like acromegaly, which have significant increased risk of colorectal cancer, the MAP kinase, P38, and JNK pathways, which are very pro-oncogenic, and also this idea of the relative imbalance in adipokines, so changes between leptin and adiponectin, which again we've seen in other from the oncological field about this very subtle balance between the kind of negative or anti-inflammatory adiponectin and quite pro-inflammatory shift to leptin production in those with malignancy. And is there genetics that are underpinning it? So again, the genetics that are probably most important are probably those constitutive changes in SNPs and background mutations that the background population have in general. In terms of our liver-specific mutagens, so PNPLA3 probably been the most obvious one that we know has significant increased risk of more advanced liver disease, but also in terms of the I148M mutation predisposing to HCC risk, actually the data in terms of extrahepatic malignancies is incredibly inconsistent. There may be a subtle signature in women, and there probably is what may actually be an apparent protective effect, but actually when you adjust for all of the other confounders within the field, actually this is probably attenuated completely. And again, thinking then about more upstream changes that we can see in the epigenetic phenomenon. Again, almost certainly they're involved, but rather than being primary drivers, they're probably secondary bystander effects in relation to the inflammatory perturbations that we see already. So we're looking at some of the key data. So I think I've picked two big meta-analyses that I think are probably the seminal works, and I would point to Alessandro Mantovani's as probably the most comprehensive review that you can find. It's slightly older. It was published in 2022 in Gut, 2022-2023, and looked at 10 unique observational cohorts with very stringent criteria that were applied, and that they looked at published data between 1996 and 2020, and used much of the NAFLD definitions. But we'll look at some of the intricacies of that study. And then a more recent study by a Chinese group from Benzhou, who again looked at a slightly broader definition, but managed to find 18 discrete cohort studies up until 2024, some of which include definitions from both MASLD and MASLD. So it's probably a bit more contemporaneous, but there's some pros and cons with both of these studies, but hopefully you get a flavor for the epidemiology involved. So in terms of the principal outcomes, in terms of the Mantovani paper, so we've seen that MASLD or NAFLD was described in the paper, was associated with 1.5 to almost twofold increased long-term risk of developing GI cancers in particular. And this is probably the most important finding, probably for our patients. And we've seen an effect on esophageal cancer with pooled random effects of almost 2, an 80% increased risk of stomach cancer, and an 85% increased risk of pancreatic malignancy. And that was all encapsulating pancreatic malignancy, not just adenocarcinoma. And I've just included some of the screenshots on the right, and that's just to see the kind of hierarchical approach that they took for the study. So they used NAFLD by definition using ultrasonography, using ICD coding, and then some studies that used biopsies and approached them as kind of categorical disparate studies. So it was a very nice way of doing it, very labor intensive, but provides some very granular data. And all of these were adjusted for confounders, including age, sex, smoking, obesity, diabetes. What else did they find? So again, did notice increased preponderance of breast and gynecological cancers, and again to the magnitude of hazard ratios of 1.6 or 60% higher risk of all conglomeration of gynecological malignancy, and a 40% higher risk of breast cancer. They also noticed one of the strongest effects that we've seen in most of the observational cohorts was this very close association with colorectal cancer. But the meta regression did notice also this kind of synergistic interactive effect of smoking which made the finding even stronger. When we looked across the zoo paper, it was slightly different in terms of how they corroborated all of their findings. But their main things I've just highlighted in red here was to look at, again, the colorectal cancer, gastric cancer. They didn't find an esophageal cancer association, or they did split out into head and neck as well. And they looked a bit more in detail in terms of things like thyroid cancers, and they split out some skin cancers and brain and CNS as well. And again, found statistically significant findings. Again, the number of studies are pretty low, and there is some bias associated with some of those. So in all, certainly there was again a trend towards increasing numbers of gastric malignancies, colorectal cancer, and pancreatic. Again, they've separated out biliary tract rather than including them, and then developed some of the ideas around thyroid, urothelial malignancies, and breast cancer, again, showing similar findings to Alessandra's paper. Interestingly, they didn't find the same esophageal outcomes. They didn't find any association with lung, prostate, or small bowel, which again I think can be very arguable in terms of how rare a malignancy it is in general. And again, it seems a slightly idiosyncratic finding to consider. So overall, in terms of thinking about the papers individually, which I said are probably the two most comprehensive papers you'll find, there was a paper in 2020, again, undertaken by Lou, which again included a lot of case cohort series. But certainly I think Alessandra's paper is the most robust mechanistically, and they use this very nice hierarchical approach to ascribe a diagnostic label. The zoo paper had excluded some cross-sectional and case control studies, which they feel have introduced some bias in the previous literature. But they did include some of the MASLD criteria, which again, we know that the outcomes are probably slightly different, but it's probably a reasonable thing to include in terms of conglomerating the data for extrahepatic malignancy. One of the challenges with the data in general is the idea of how do we define an inclusion criteria. And I think this spans most of what we see in MASLD and SLD a bit more broadly. So some of the study used fatty liver index as inclusion, some will use ultrasonography findings, some will use ICD codings, and others have relied on only having mechanistic or biopsy included cohorts. So again, there is probably significant heterogeneity irrespective of how you want to adjust for bias. And these individuals and how they're recruited probably represent individual and discrete cohorts of patients with differing risk compared to possibly the background population. So I think going forward, one of the things that we will then begin to see, particularly with the advent of new treatments for MASLD in particular, and how we're going to use some of the kind of spin-offs from the NITs. So looking at CAP, the attenuated parameters for fat measurement using transient elastography, the development of MRI-based modalities, including PDFF, and also some of the other proprietary types of fat definitions. So thinking about what our treatment approach is, I would simply just argue that it's just going to be modification of risk factors. And I think from the bariatric work that will essentially be modulation of adiposity. And I fully accept that not every individual is suitable for bariatric intervention, but actually I think we're coming into an era where the needle has shifted on that in terms of some of the therapeutics. The other thing is also to not forget the competing risk, and that while we're very focused on extrahepatic malignancy, and I haven't even considered HEC as a discrete outcome as well. But again, the vast majority of these patients have significant cardiometabolic risk and are likely to succumb to that. So what can we do? So again, I think doing the simple things well. And I think even though we have new therapeutics, we should still be engaging our multidisciplinary teams, accessing our dietetic services, encouraging ongoing regular exercise, which has significant improvements in cardiovascular disease beyond weight loss, and effective weight management services, which can introduce and begin to augment that service with the pharmacotherapeutics, but we shouldn't be entirely reliant on using some of the drugs. But in saying that, I think it's hard to be excused from not touching on the pipeline of anti-obesity drugs, which is really incredible. And we think at last count, we're in the realms of somewhere from 70 to 120 drugs, either in phase 1, 2, or coming close to regulatory approval. And this is just from a very nice meta-analysis that looked at some of the ones. These are some of the ones that are already in phase 3, and you'll see the principal mechanism of action is again focusing on GLP-1 as the receptor of choice, which we're we're very experienced, and we've had exenatide for over 20 years, and we're now onto our second and third generations with augmented targets, which are including GIP and glucagon receptor agonism, to achieve even more pronounced effect in terms of weight loss. And again, looking at MASH in particular, we're likely to see semaglutide having an active label for fibrosis regression. But again, a lot of the changes that we're seeing are probably related to the significant weight loss that these drugs induce, although not exclusively. But again, we're seeing some of the newer agents, so even though SGLT2 inhibitors don't also induce significant weight reduction beyond maybe 5%, again, we're now seeing that the recent BMJ publication showing that, again, showed significant fibrosis regression in a Chinese cohort. We're also seeing some really new and novel targeting. So we'll see on the right-hand side, you have the GLP-1 and amylin analogs, whilst in phase 2, and some of these are some of the trials that are not even read out yet, we can see again newer effects and things like growth and differentiation factor 15 agonists, melanocortin becoming of interest again, and again mixing semaglutide with secondary neurotransmitters, so neuropeptide Y receptor agonists. And again, the vast majority of these are already reading out incredibly successfully in terms of inducing weight loss in the realms of 7 to 25%, depending on mechanism of action. And there's also group specific. So again, one of the things that's probably not spoken about as much is knowing that the weight loss is more significant than those without type 2 diabetes, whilst those who already have established insulin resistance probably have a significant reduction of about 50% of those that are often presented in the literature. So I think, again, we need to, as hepatologists, we need to really move beyond the liver focus, and we can put steatotic liver disease and whatever badge we want to in the center of the focus. But again, wrapping around that holistic care and thinking about, we have significant tools in our armamentarium in terms of reducing inflammation, reducing adiposity, and reducing the other secondary metabolic effects. But again, we know that if we can reduce adiposity, naturally people's blood pressure should get better, their diabetes should improve. So again, we can choose to focus simply on obesity as our metric of choice, and we probably will have all of the secondary pleiotropic benefits in any case. But again, we will also see, again, some changes in terms of the definition of obesity, which will provide some challenges in how we define that. So in terms of our anti-diabetes medication, again, this is really where a lot of the benefit has been derived already. And we can see that, again, it's really just exploiting the benefits of these drugs across multiple aspects of improvement of steatosis, MASH resolution. And again, the idea that we're splitting between MASH and just simple MASLD with fibrosis is that with the idea that the pro-inflammatory and pro-necrobiosis of MASH is, again, a measurable target that improvements in inflammation slows down fibrosis progression, but again, probably also improves outcomes in terms of metabolic and cancer risk going forward. So just very briefly, in thinking about metabolic procedures, so again, not everybody will tolerate the anti-obesogenic drugs. So we think about 15 to 20% failure rate, although depending on how patients titrate to effect, that may be lessened, but they're certainly off some negative side effects that patients do not tolerate. And we've seen some interesting data then around intragastric balloon making somewhat of a comeback or resurgence, and duodenal mucosal resurfacing. Again, there's been 2 or 3 recent studies, again, looking at improvements in insulin resistance and weight loss of modest amounts between 8 and 12%. But I did want to focus just on this idea of bariatric metabolic surgery, because again, I think for a select group of patients, it probably provides the most robust long-term benefit. And that's one of the things that we have to think about in terms of the pharmacotherapeutic effects, is that they're likely to be drugs for life, and that comes with considerations. And so again, looking back to this study of the association between bariatric surgery and major adverse outcomes in terms of both liver and cardiovascular disease, in those biopsy-proven effect, again, we've seen significant improvements in those individuals who underwent bariatric surgery compared with those that didn't. And that was across both incidents at 10 years of major adverse cardiovascular outcomes of 8.5% in the bariatric group versus 15% in the non-surgical groups. And overall, the amount of adverse events in the bariatric group remained low, including initially post-operative, there's about a 6% complication rate. So again, within the realms of acceptability compared to some of the other drugs that we use. I think this is a fantastic study from Italy that probably doesn't get enough attention really. And again, it's really this head-to-head between bariatric surgery versus, optimized lifestyle interventions and best medical care in terms of anti-obesity drugs. And I appreciate they used liraglutide as their GLP-1 of choice. And it was an open label trial, but I think the findings are so dramatic in this that again, we really need to reevaluate how we offer these services to individuals. And again, moving beyond just improvements in cardiometabolic risk and liver risk. And again, coming back to what we said very early on about this idea of cancer risk becoming that essentially of the background population. And this was, again, within Braves, they used both Roux-en-Y and sleeve gastrectomy, and they're both essentially relatively comparable, but both superior to the other intervention. One side note about metabolic surgery that I haven't mentioned, I don't know if people are friends of House, but House is our American colleague who is very scathing of patients and their ability to tell the honest truth. And one of the things that we have seen emerging from some of the bariatric cohorts is the evolution or development of complications in terms of alcohol use disorder and the potential risk of developing alcohol-related liver disease. And so it does come back to being very fastidious in our selection criteria, but also being better at assessing patients for their alcohol intake. And I do want to kind of verge on this somewhat because I think certainly in the UK, and it'd be great to hear your experience in Italy, is really that the vast majority of our patients, if not when they're sitting in front of us, but at some point in their distant past, probably far more resemble MET-ALD or ALD compared to the individual that we see who's presenting at 65 years of age, who's got F2 or F3 and is now teetotal for 5 years, but had 20 years of having a reasonable alcohol intake. And this is just a really nice paper from Katrina Stauffer and the team in Vienna. And this was really just to show that for the most part, patients probably underestimate how much they drink. But also, again, this dynamic shift and the ability to show that patients that were very categorical and deciding that they had NAFLD actually could be recategorized based on using more objective measures. And I think that's a really important thing, not to catch patients out, but just as part of our educational and interventional strategies, particularly as we see, again, as a mechanism of action, we see things like semaglutide producing benefits in terms of their alcohol reduction. And so really in this study, you just show that essentially almost 30% of individuals who would have been labeled as NAFLD probably could have been reclassified far closer to alcohol-related liver disease. And again, speaks to this idea that alcohol will inadvertently put up your lipids and you can become dyslipidemic and you, again, can develop adiposity and obesity. And so again, being very clear in our labeling is probably important in terms of predicting patients' outcomes. So does it matter? Well, alcohol is a potent carcinogen. In fact, it's a group 1 carcinogen. And here, I think already is going to become a real focus of discussions here. And we'll see that in Ireland was about to become the first country in the world to actually put true warning hazard advertising on alcohol, as well as their minimum unit pricing, so that patients and citizens have a right to know. So again, it's just looking at this interactive effect. And again, we've seen that, again, the risk of MET-ALD and the synergism between obesity and alcohol produces far worse liver-related events. And then just very fortuitously, there's a really nice meta-analysis has just come out looking at, again, this idea of the differences between hepatic and extrahepatic outcomes for those who have discrete metabolic MASLD versus MET-ALD. And this has literally just been published in Lancet GastroHep this month. And it's synthesizing data from 24 observational cohorts and includes essentially 11 million individuals, almost 10 million with MASLD and 2 with MET-ALD, which again, actually, in looking at some of the other systematic reviews and analysis of looking at the actual prevalence, that's probably about the split when people have looked back retrospectively to see where people better fit into these categorizations. So it's understanding of the differential between these two discrete conditions and their outcomes. As we said, we had almost 11.5 million people with SLD, and this split between MASLD with, again, a predominance of male individuals, which is unsurprising and certainly our experience locally. The median duration of follow-up was 13 years. And again, there's this very clear signal that MET-ALD is associated with significantly higher risk of liver-related events hepatocellular carcinoma, but also extrahepatic malignancies. And this maybe speaks to this idea that obesity is certainly a risk factor for extrahepatic malignancies, but if you introduce a class 1 carcinogen, that risk probably goes up even further. And again, speaks to what we should be able to explain to patients. But again, even for those with very little fibrosis, if you have MASLD, maybe there is no safe amount of alcohol even within recommended limits, as we do for people with chronic or advanced chronic liver disease and cirrhosis. But interestingly, the team have found that there's actually no significant difference in major adverse cardiovascular events. But really importantly, for those individuals who did develop extrahepatic cancer, there was no difference in their mortality. So again, a really interesting, important finding. So I think in terms of thinking about going forward and where we should be heading, I think enhanced stratification is really important, thinking about reclassification of individuals as MASLD, but again, the ability to flux between MASLD and MET-ALD. And again, every time we see patients is an opportunity for intervention to really nail down and refine alcohol risk, which is clearly deleterious. We can also then think about targeting metabolic pathways in terms of dampening down inflammasome and inflammation, which should reduce risk. But again, if that's just as simple as targeting obesity, that's, I suppose, one of the more open questions that we need to think about. But certainly addressing the obesogenic potential should improve most of the other metabolic parameters and is probably a very objective endpoint to aim for. As we said, if we can find novel immunomodulatory drugs, they're probably going to be very expensive. But again, we'll probably see some other advantageous features of some of the newer therapies, which are probably more liver directed. So if you think about resmetirom, it's got some improvements in terms of lipid profiles and things that may have benefit for cardiovascular outcomes, although we haven't shown that yet. But again, it's about harnessing those other potential benefits. And again, I think really coming back to our future approaches, we really need to then come back to this public health approach to mitigate the development of MASLD long before these risks take hold and send people on a unidirectional path to developing cardiovascular or neoplastic risk. And I think that's everybody's role in tackling the disease. One of the things I tried to think about a bit more as well, and to look for evidence around really is, should we, if we know that these individuals are at increased risk of cancer, what should we do in terms of screening? And actually, there's certainly no evidence to suggest that additional screening should be offered to those out with national screening programs. But we should be encouraging all individuals to be engaged in colorectal cancer screening, to be engaged in breast cancer mammography, and follow up with appropriate specialists as necessary. So again, I think just standard routine population levels of care are probably the only evidence and certainly cost-effective option that we have at present. So just in conclusion, I think there's a clear link between MASLD and cancer. Whether that is just principally driven by obesity, I think is a matter for debate, but certainly we see that there's certainly a higher risk of extrahepatic malignancy, and this is mediated almost invariably by shared metabolic and inflammatory mechanisms. Prevention and treatment is absolutely pivotal, and this really just mirrors what we see in the obesity space, and therefore then we can target the other aspects and the sequelae of obesity and metabolic dyshealth using non-pharmaceutical interventions. And now we have an increasing access and armamentarium of pharmacological and potentially surgical interventions. And again, that needs to be better defined and who's likely to benefit most from what approach. And this needs to align with local, national, and international availability and where expertise exists. And in terms of screening, I don't think there's any significant evidence base at present that would mean that we should shift base to offer additional screening for these individuals beyond optimizing their cardiometabolic risk and improving their overall obesity risk. Thank you again very much for a really kind invitation to speak, and I'd really welcome any questions, discussions, or points.
Okay, thank you very much.